Hello, everyone. My name is Paula Neves, and I'm the lead for the Center for Living Organ Donation. Thank you for joining us at today's session on pain management pre and post liver surgery. We've got two excellent speakers that will be taking you through a lot of content today. We welcome your questions. You can submit them via slido.com, and the code is liver. So slido.com, and the code is liver. So I would like to welcome our two speakers. We have Dr. Hans Clark. Dr. Clark is Director of Pain Services and Medical Director of the Pain Research Unit at the Toronto General Hospital. And he is appointed to the Institute of Medical Sciences at the University of Toronto and is also a graduate of the Royal College Clinician Scientist Program. And we have Dr. Daniel Santamina, who is an assistant professor at the University of Toronto in the Faculty of Kinesiology and Physical Education, and is also cross-appointed to the Faculty of Medicine in the Department of Surgery. Dr. Santamina is also a clinician investigator at Toronto General Hospital, and he is affiliated with the Research Institute within the Department of Anesthesia and Pain Management. So both of our speakers will be taking you through an extensive deck. Again, we welcome your questions. Please submit them to or via slido.com, and the code is liver. I will now turn it over to Dr. Santamina to take us through the first part of the presentation. Dr. Santamina.
Great. Thank you so much, Paula. It certainly is a real pleasure to be with you all today, and I want to express my appreciation to the Center for Living Organ Donation for having me and Dr. Clark. I will test the slides out and try to move forward here. The presentation today is entitled Pain Management, Pre and Post Living Donor and Recipient Surgery. And as Paula mentioned, the focus of some of my work is prehabilitation, and I think this is a very exciting topic with respect to transplant. So today, the objectives are to learn about prehabilitation prior to surgery. The vast majority of the research, it goes across a number of different types of surgery, not necessarily just transplant. So I'll try to consolidate some of the information, but speak specifically to some of the transplant-related issues and some of the data that have emerged recently. Dr. Clark will then help everyone learn about the typical care pathway that transplant patients, both donors and recipients, will receive, as well as the postoperative innovations that are emerging at the Toronto General Hospital. And overall, we hope that you will also gain some insights with respect to research in medical cannabis, as it may improve pain for organ transplant recipients and donors. Okay, so we'll get the topics started with prehabilitation. And as you can see here, maybe this is a little bit similar to those who are in Southern Ontario. We've got a rainy day today. This, in fact, is a picture of the Boston Marathon. And this is at the finish line, and you can see some people are smiling, some people are grimacing and cheering and so on and so forth. But everybody had worked extremely hard to get to that finish line. This didn't just happen overnight. There was a lot of training, a lot of planning. There was a lot of mental preparation, physical preparation that went into getting to the finish line of this pretty grueling race. Now, in my world, very often, this is another challenge that people face. So sometimes my students will be cramming and struggling and stressing over their various exams that do have important implications for a number of different, I guess, postgraduate career plans. And in preparing for these exams, we expect that that preparation should improve their outcomes, because the exam really is a stress. It is a challenge. And similar to the marathon, if you don't go into it prepared, you don't do as well during that challenge. And many facets of life do comprise challenges. And in particular, what we're talking about today relates to surgery. And really, that is a very significant challenge that people do have to face. And there are a lot of physiological and psychological stressors associated with surgery that people must be prepared for to do their best. So surgery is a challenge, I think, that we need to think about being prepared for. And when we think about performance, whether it's on an exam or in a race, we want to make sure that our health behaviors are aligned with adequately preparing us for that challenge. So we want to make sure that we're eating well, we're maintaining healthy fitness levels, we are sleeping well, we are not engaging in unhealthy behaviors. with those behaviors, we expect that our overall physiological and psychological fitness should be optimized so that we can perform at our best during those challenges. However, it's not necessarily just performance that we're always concerned about. Could it improve surgical outcomes? And so there's a lot of growing literature suggesting that by being as fit as possible, we can actually improve how well we tolerate surgery. And that makes a lot of sense because when we look at a number of the stress hormones that are secreted during exercise or during a very high intense challenge, and what our body does during those challenges, they are actually quite similar to what occurs during surgery. So making sure that we have the physiologic and psychological reserve to tolerate surgery is quite important. So in a recent paper out of the British Medical Journal, one of the authors wrote, major surgery is like running a marathon and both require training. And on the left here, you can see a picture of Ed Whitcomb. He recently passed away, but he had set a number of world records for marathons and other long distance races that were completed by those in their later years. And if you're thinking about whether or not you're fit enough or too frail or just not well enough to get in the best shape you can, just think of Ed as he was preparing for this marathon at the age of 87. So what is prehabilitation? Well, prehabilitation is a process that occurs between the time of diagnosis and the beginning of acute treatment. It includes assessing the whole patient, that is the physical, metabolic, and psychological elements of that patient, to establish a baseline functional level, identify impairments, and provide targeted interventions that improve a patient's health to reduce the incidence and severity of current and future impairments. That's a mouthful. If I had to summarize it in just a word or two, I'd say enhancing functional status before treatment means improved outcomes after treatment. This applies to surgery, but it could also apply to other health stresses that you may undergo. And often what we refer to in an even briefer statement is healthier in, healthier out. Be as well as you can before you go into the operation so you can be as well as you can coming out of the operation. And this is probably one of the earliest diagrams to conceptualize this concept of prehabilitation, where we see here in the solid line, as you go towards surgery, you stay at a particular health level, and we can expect that we're going to decline in health after surgery and then slowly recover back to baseline demarked by this hash line, and then hopefully get all the way back up to where we were before surgery. Well, the concept of prehabilitation is described here in this dotted line, where we're trying to create a bit of a buffer here, improve our fitness prior to surgery so that we have this big buffer. And although we expect to fall because surgery is a major stressor, we don't stay below this functional threshold too long. We can recover quicker and perhaps reach a new baseline afterwards. Now, these are some of the earlier concepts that have described prehabilitation, but over time, we've learned a little bit more about that preoperative space. And in fact, what we now know is that in that preoperative time period, patients' level of fitness and function and overall well-being don't necessarily stay the same. In fact, they very often decline in that preoperative period, putting them at a higher risk of postoperative poor outcomes. And that's a problem. We want to make sure that people at least stay as healthy as they were when they started. But we also know that not everybody starts at the same level. Some people start at levels where they're just teetering on that threshold of well-being. And those people are probably at the highest risk because they too will probably decline prior to surgery and then probably have this same impact of surgery, bringing them well below the functional threshold, perhaps putting them in a place where they never actually do recover to the threshold and perhaps are dependent for the long term. So these are some good rationale for becoming as fit and healthy as you can prior to surgery. What are we talking about when we're talking about prehab? We often refer to the term multimodal, meaning multiple modalities. We try to approach optimization of our health using things like medical optimization. Have we looked at our prescriptions? Are we taking what we need to take? Is that optimized in a way that makes sure that medically and the other issues surrounding our health are appropriately addressed? Sometimes it requires removing prescriptions or changing prescriptions. Other factors of health like anemia or pain may also be addressed by the medical team prior to surgery. Exercise is an area that I'm most familiar here with, and it includes aerobic exercise and resistance training. Many of you will all understand those concepts, that is training your heart and your muscles respectively. But also there may be some very local exercises in your body that don't necessarily fit into those two buckets very simply. And so sometimes we refer to those as local regional exercises. Things like inspiratory muscle training or pelvic floor training are good examples of exercises that you might do for specific surgery. Becoming nutritionally fit and optimizing your diet is very important, particularly in the transplant domain. In many programs, we often refer patients to a dietitian to make sure that they're eating the right amount of food. And in situations where there are deficiencies in certain macronutrients, there may be prescriptions for supplementation. Sometimes there's carbohydrate loading or protein loading. Psychology is another very important part of the program because there is a lot of stress that leads up to surgery, and stress hormones do impact our capacity to tolerate surgery. So stress is managed often by different management strategies, sometimes by a psychologist as it is in our program, or it could be a social worker or a nurse or what have you. But the idea here is how can we manage stress as best as we can? And beyond stress, if there are elements of distress and other psychological morbidity, how can we address those so that people are psychologically well going into surgery? And the other thing I'll mention about psychology is that a big component of prehabilitation is adhering to the nutrition and exercise and perhaps smoking cessation regimens. But that can be quite difficult, and some psychological strategies can make that a bit easier. And for those who do smoke, a referral to a smoking cessation program is highly recommended, as the benefits of smoking cessation prior to surgery are extremely well documented. So when we think about the timeline of someone who's approaching surgery, there's a pre-diagnosis or pre-decision for treatment. They may be listed as a transplant donor or transplant recipient or other surgery, if you will. And then there's this period of time where you're just waiting. There's this pre-treatment space. Well, we often think of that as a waiting game, but I'd like you to reframe this entire time as a place where your treatment has actually already started. As soon as you've made a decision to donate or receive a transplanted organ, can we start our treatments there, including getting ready for treatment with prehabilitation, where we turn this waiting game into something more like an opportunity. And the opportunity, as we've shown in the literature, has actually been quite important to improve a number of surgical outcomes. The research on prehabilitation has grown rapidly since the 2010 and onwards, when Dr. Hans Clark and I both got into this space more intensively. And you can see that it's just been an exponential growth, more or less, over the last 10 years. And so it's on that growth of research that we could describe some of the benefits, largely which include improved physical function before and after surgery, paired with improved psychological and cognitive function over those time periods, shorter length of stay in the hospital in and around surgery, as well as fewer surgical complications. So the benefits, as you can see, are quite robust. And in addition to the improvements in patient health, there are a number of economic implications of prehabilitation. I won't spend too much time on this particular slide, but basically in a number of different studies, they've demonstrated that we can save money in our healthcare system with prehabilitation due to the reduction in complications and length of stay days that are observed in those who are non-prehabilitated. So if we were to direct our attention a little bit more towards the concept of prehabilitation for those who are undergoing organ transplant surgery, there's a very recent paper, and this is just published in the last few months by Dr. Jonatas Freire and colleagues in clinical transplantation. And they reviewed all of the literature looking at prehabilitative exercise prior to organ transplantation. And over the last number of years, they found that basically there are 23 articles that address this particular topic. And I'll share with you a few study highlights very briefly. There were 23 studies that were included. They represented over 2,000 participants, and eight of these 23 studies were randomized controlled trials. And what that means is there is a high level of study quality among these 23. These studies have included patients undergoing lung, heart, liver, and kidney transplantation. They generally found that those who were offered prehabilitation were willing to take it, with an acceptance rate or a participation rate of 97%. There were no adverse events reported, although some of the data were not all that well reported, but thankfully, no adverse events. And while improvements in exercise capacity are a little uncertain based on the data, there is some indication that the longer period of time that patients spent prehabilitating, the more benefits were seen. So when we think about more broadly quality of life, they use a particular questionnaire that's very commonly used in research that looks at quality of life across a number of different domains. And what I've highlighted here is that there is some signal that there's some positive benefits in prehabilitation compared to controls. So it's not necessarily all that convincing yet, but again, this little area of research is very new, but there are some positive findings to take home. Okay, so getting towards the end of my time here, there are a few questions that probably a lot of people have with respect to prehabilitation prior to organ transplantation. But first of all, what is the optimal patient population to target? In my opinion, it's everybody. Nobody is in perfect health. And in areas where you can improve health, I would suggest that you do your best to do that. That being said, from a hospital or from a health system perspective, we do try to focus on those who are most frail. So those who have more health issues than those who are others, we probably would focus on those with conditions with like deconditioning and so on. What is the optimal prehabilitation regimen? As I noted earlier, multimodal is generally the way we try to go. And it doesn't necessarily mean that everybody has to do all 5 components, medical, exercise, diet, psych, and smoking cessation. But really any areas that you find that there are health deficiencies, you should try to address with a modality that is specific to you. So every prehabilitation program should be individualized to the person, aimed at optimizing areas of deficiency and improving overall health. What is the optimal timing for a prehab regimen? Well, this really does vary depending on the period of time that one is waiting for surgery. If you only had a couple of weeks, well, then I would say maximize that 2 weeks as best you can. If you only had a few days, well, I would focus on stress reduction and resolving any acute dietary deficiencies, and perhaps planning for rehab and making sure that you're aware of the rehab protocols that are likely to follow surgery. But ideally, the optimal timing is as soon as you can, all the way until the day of surgery. And what about the donor? At least to date, there's not a lot of evidence specifically on prehabilitation for the donor, but I would suggest that the concept still holds. Donors are generally in good shape, but are they in as best shape as they can be? Sometimes not. They may be fit enough to donate. However, could they be in even better shape so that their experience with transplantation is even better? So just a few things to wrap up with. From our data at the Princess Margaret, working with some patients, and these voices are specifically those women with breast cancer who participate in prehab, they describe a lot of benefit from their participation, especially as it comes to feeling in control and empowered as they approach surgery, and that it has set a good stage for recovery. And in addition to the patient's voice, what are the surgeons saying? Well, in this particular quote, the idea here is that patients have indicated that the surgeons have indicated that they've referred to prehabilitation to optimize health, to improve outcomes, and in such a way that the surgeons have felt that it's made a difference. So that is a very, very quick primer on prehabilitation, even though I'm a few minutes over. And I'm just very happy to say that at UHN, we've been working very hard at trying to establish a clinically integrated prehab program. And we hope that all patients, both donors and recipients, will be able to get optimized prior to their transplant experience. Thank you, and I will turn it over to Dr. Clark.
Thanks, Daniel. Since you're my slide advancer, you can move to the next slide. Thank you very much. And when we met with the patients about a month ago, talking about what they'd like to hear about, it's a great segue. You really set the stage in terms of what can be done before surgery, but there was also an interest in, what are we doing today? What are we looking to do tomorrow? And what are some of those innovations that we've done here? And finally, I'm going to wrap up with about 10 to 12 minutes on medical cannabis, because this seemed to be such a hot area of conversation. So if you can move ahead, Daniel. This is what happens in any of the donors. I know there's both donors, recipients, and probably a wider audience that have tuned in here. At TGH, if you come in and you donate a liver, you will typically end up with your IV PCA immediately postoperatively, and you're transitioned to an oral regimen with non-steroidal anti-inflammatories or Tylenol by post-op day 1, and off of all IV support by hopefully post-op day 3 if things work well. The kidney donors have evolved significantly to the point where we still give everybody their IV PCA, but they are typically within the first day or so already on multimodal analgesia, and sometimes transitioned off of their IV PCA if they're doing well on day 1. So the next slide relates to the recipients. And you can see that clearly these are quite different surgical operations. They're quite different in terms of their size and scope of incisions. And those are typically the factors that lead to, the complexities that can sometimes occur from a pain standpoint, that is. And so our liver transplants almost, depending on how the course goes, depending on how complex the surgery is, and sometimes, not all recipients go into the operating room at the same baseline state, hence the discussion about rehabilitation in general. Some folks, remain in the ICU and may or may not actually need an IV-PCA. So it's about 50% of those liver transplant recipients that end up having an IV-PCA is an intravenous patient-controlled analgesic pump that typically has an opioid such as, morphine, hydromorphone, or potentially fentanyl if there are sensitivities to the other two medications. And by about 3 days, those liver transplant recipients typically might be off of our acute pain service. Providing that everything goes well, they move forward and head to discharge. If there are any complexities, I'll get into some of the possibilities where some of these patients may land. The lung transplant recipients clearly are some of the more challenging. They have the most painful intervention. We've created a pathway now where on the post-operative day 1 or 2, they're actually assessed specifically from an incisional pain perspective, their ability to breathe, things of that nature. And we now will come up with some newer regional techniques that can be implemented, things such as erector spiny plane blocks. Some of these local anesthetic catheters can be left in place for some of these folks. Kidney transplant patients, again, do typically well. By 1.5 days, I would say they're often off of our acute pain service. And from a pancreas or a KP transplant perspective, some of these might occasionally be given an epidural based on surgical preference and what their pain history might be. And again, these last a little bit longer. They're probably with us for anywhere from 4 to 7 days on our acute pain service, and then they're transitioned off. So, what can you expect on the horizon for some of the, innovations in pain care? There's always a bit of a challenge when we're dealing with transplant donors in particular about how invasive we can be and what we can actually offer our patients. But I can tell you that the IV lidocaine and IV ketamine, as part of kind of this multimodal analgesia pathway, is in the works. We have rolled this out from 2016 to 17. We have 3 to 4 years of data at the hospital level showing its safety. We are now approved to run IV ketamine on wards, even outside of our step-down beds and bays. And we're really just waiting for the go-ahead from the transplant services to start to implement this. The next slide shows the ability of us to safely provide these two treatments perioperatively, IV lidocaine. There was a bit of a concern amongst those that might be having extended liver resections. And so, lidocaine, how does that work? Well, it's a sodium channel blocker. What does that mean? It's a global down regulator of your nervous system. And so one of the things that people realize is that when someone comes out of surgery, they're just not quite as, robust as an individual who has not had an infusion of lidocaine. Now, if you were trying to go home within 2 hours after your operation, I can see how this would be a big deal. But, as far as I'm concerned, a little bit of sedation after such a major surgical intervention is neither here nor there. And I think it's something that we can easily implement safely moving forward. As well, we've been, as I said, rolling out ketamine since 2017. The biggest issue with ketamine is obviously the possibility of hallucinations, which has been documented in the literature. But at the doses we run, it doesn't tend to be a big deal. And it really depends on whether those hallucinations are positive or negative, to be completely honest with you. And so something that we will completely look to roll out as well over the next months to years. And so I can tell you that the mechanism of action for ketamine is an NMDA antagonist. What does that mean? It works primarily in the area of the spinal cord and the central nervous system that relays the message to the brain, and it dampens that down. So those are the two mechanisms for those two medications. Now, if you move to the next slide, the one thing that we do have at the Toronto General Hospital, and we've just been highlighted, there has been a Canadian task force a report in May of 2021, so just last month, that highlighted our innovation in care at the Toronto General Hospital as being one of the biggest Canadian advancements in pain care over the past, 5 to 10 years. And so if you advance the slide, Daniel, I can tell you that, one of the things that we do from a transitional perspective, when we developed this program, it was really looking at those individuals that were having a problem in the acute pain setting, and then figuring out who went on to have a chronic pain problem. And that was where things were evolving from. The word transition can have many meanings. It can be a transition from adolescent to adults, from the hospital to the community. And I can tell you, given the backlogs from COVID, that transition from hospital to community has become such a hot area where there's lots of potential resources in terms of how we can do that a bit more readily, as well as whether we can do it virtually, et cetera, et cetera. And of course, given we are in the midst of the opioid crisis, how do we transition people from their super high dose opioids that have been on these medications for years to low dose opioids, et cetera, things like Suboxone, buprenorphine, and how do we help people wean off of some of these medications? And so, when we move this forward, Daniel, yeah. We know that the three pillars of any type of pain management, the easy part is the medical part. So the things we do as physicians, the medications you take, the things that can help with some of those, neuropathic symptoms, things of that nature, the rehab and prehab, prehab, physical exercise. I think Daniel has stressed the importance of that. But one of the things that have been really left behind in the late 90s, I guess, was the psychological component. And we've really planted ourselves on the map as being the program that integrates both the complementary parts of medicine, the psychological aspects of medicine, into our everyday working environment. And so the next slide, Daniel. This is some early results I'm going to share with you, because I know one of the questions was, how about mindfulness meditation and some of those issues? And what we did, we just finished a 92 patient RCT. I presented this at the Canadian Pain Society last month, hence the letterhead here for the slide. And what we found was that a single clinical hypnosis intervention before surgery, and one done immediately in that early postoperative period, has some effects, not only early, but within that kind of first week to month, sometimes after surgery. And so the next slide demonstrates that, one, there's a bit of an early, opioid sparing effect very early in that first 24 to 48 hours. And the slide after that speaks to this kind of pain catastrophizing, where they're ruminating about your pain and, oh my God, is this going to get better? What's going to happen to me long term? And that occurs probably about a week to 2 weeks out after surgery. And so you can see that there is a direction here towards, not just what we can do from medication standpoint, but how you can use your brain to help control your pain as things move forward. Next slide, Daniel. So this is one of our more prouder achievements. We've now become a completely digital program, in that, when COVID launched, we didn't have the ability to continue to track some of what we were doing in the clinic with the outcomes that patients were having, because we moved from seeing patients in person to completely virtually. We're still at about 85 to 90% virtual. We'll see if that ever evolves back the other way. My guess is we'll probably land at a medium of about 50-50, and maybe even more so on the virtual side. And so, what we have partnered with is a company called Managing Life, who has a program. All of our patients log in. They give us their questions and their answer our standardized questionnaires beforehand, and then we see them virtually, not losing a beat. And we were able to do that in about 2 or 3 months, given that patients were, now not being seen. And there were very few programs that were able to do that. And what you'll notice is, one of the things we don't focus on are asking you all of those numbers. We still collect that, but what we really want to know is, how you're doing, and whether what you've done in a day mattered to you on that day. And that is always my take with many of the patients in our program. I often hear that, Dr. Clark, I've been in your program for 2 or 3 years and you've done absolutely nothing for me. My pain is still 7 out of 10, and it was that exactly 2 years ago. And I'll say to them, oh, weren't you wheeled in here by your loved one, and today you biked in to see me? And so, reframing things in terms of not focusing on numbers and actually getting your meaning to your life back is really our mindset when it comes to our program. Thanks, Daniel. Next slide. We went on to publish, just our integration of this mobile health application into the service. I think this was just late last year, maybe November of last year. So if any of you have interest in that, you can always pull that up. Next slide, please. So this is where it's now become pretty interesting for the transplant patients. And so these are literally 4 papers that I was able to pull up in the last year to 2 years, looking at survival and looking at trajectories as you proceed from surgery based on your pain characteristics, your medication characteristics, and whether you were taking an opioid or a benzodiazepine. And so 2 of these papers are in the lung population. One identified that they couldn't find an association between medications being taken preoperatively and outcomes. The other one had a completely different story, which was that anybody taking prescription opioids at a specific number or benzodiazepines had significantly worse outcomes following their transplant surgery than those who were not. And there's a recent paper just in the liver transplantation population demonstrating a pretty high incidence of neuropathic pain or chronic post-surgical pain as a consequence of some of their interventions. So I'm going to present in the next slide some data just speaking to, and we're working on this paper, speaking to the number of patients that we've seen in our transitional pain program in the last 5 to 6 years. We have seen 74 post-lung transplant recipients, 36 liver recipients, 15 heart, 14 kidney, and 3 liver donors. And, this speaks to a couple of things. One, either the donors really are just doing so much better, or perhaps there's a different care pathway. And you can certainly see that, this post-surgical support is something that is needed and is something that is becoming to be highlighted in the literature as the number of patients grow and obviously the number of donors grow. I understand UHN has now had their 1,000th liver donor, and congratulations to the successful program. And so, we'll continue to keep an eye on this and move things forward. So the next couple of slides really speak to just some highlights in terms of what we're seeing as we're looking through this data and going to publish this in the coming months, hopefully. So what we found was when we start to look at some of these complex patients, and I didn't want to dive too much into this, so I left it out to thus far, but we are seeing a higher instance because as the population of patients grow, the ability to have a transplant becomes more generalized. And so there's a significant correlation of an addiction history, and those patients that we saw, 50% of males that we saw in our program had a documented addiction history prior to receiving a transplant, and maybe the opioid crisis has something to do with that. And whereas that number was 13.3% in females. Now, to highlight some of what we are seeing and what we're going to hopefully be able to find from statistical endpoints, which we've done some prelim stats, is one, we're definitely, if you land with us, we're seeing a reduction over time from the time you start with our program to the time you end, with your reduction overall in your pain severity. From an opioid consumption standpoint, 90 milligrams is this magic number that the world now accepts as the peak number of someone being on an opioid long-term that does not have cancer. And so about 25% of the population, when they started with us, were above this number. And by the end of it, we were down to about 16% of the population. And again, spoken to the fact that, we meet you where you are. We're not forcing you in any direction, and we're just giving you added adjunctive therapies and medications and psychological tools to cope with the pain. And one of the things we have to understand is chronic pain or chronic neuropathic pain. Once you have this symptom for over 6 months, you're probably going to have this on an ongoing level. And one of the things we do is we make that pretty clear at the outset. I think promising individuals that we can fix their chronic neuropathic pain is unfortunately not the right way to approach this. And having people understand how we can return you to something that's meaningful, even with this in the background, is the best way to approach this. And in medicine, we're not really good at delivering that type of news. We like to talk a lot about cure and fixing things. And so, that's not the best approach we found. And we all know that surgery in of itself, and one of the reasons I think that there is so many resources towards ensuring that a donor is ready for surgery, is that there is a strong amount of literature that surgery itself has a trauma component to it. And so by the time those that are struggling with some of these postoperative pain conditions, and I just want to take a moment to say that, remember, this is a minority of the population, not the majority, but those that are struggling with some of these issues are much less traumatized by the time they are done with our program and are able to cope and move forward. So next slide, Daniel. This is a simple slide to show you that because we were highlighted in that national pain program, we were also funded by Health Canada to create a resource to help others build similar services. And so this is live. We will have a roadmap for other countries and other jurisdictions in Canada that would be willing or interested in building these. They have already built a program in two in Vancouver, actually, one in Calgary, one being built in Halifax. And so it's something that is certainly taken off. Multiple centers in the US have followed our lead, as well as other countries in the world. So I'm going to finish off by talking to you about the good old cannabis. And, this is something that Canada has embraced. We have decided, for better or for worse, that this is part of our society. And the government has decided that, it is on par with alcohol, and we will tax it, and it will continue to grow. So I just put this number, this bar graph up here, just to show you the increase in spend on a monthly basis in Canada for medical cannabis. And so the number as of December 2020, I should update that, was about $195 million being spent on a monthly basis in Canada. If you ask the Canadian population, and one of the most recent Canadian statistics, StatsCan survey, found that 2.7 million Canadians identified as using cannabis for a medically or a health-related condition. And so if you think about that, that's almost 10% of Canada. We have 37 million people, so call that 3.7 would be 10%. So let's call it 3 million, but only 500 to 600,000 of those individuals were actually using cannabis from a licensed producer or using it with some type of validity or reliability to the product they're using. So they're either accessing it from a sidewalk dispensary or someone that they know that would give them a product. And so you can see that there really isn't a ton of guidance to move or help our Canadians figure this out. And so it's been something that we're trying to tackle in a meaningful way. Next slide, Daniel. One thing that's for certain is that much of the data that we have in and around whether cannabis is even useful for not just pain, but for sleep, anxiety, depression, all these things comes from the pharmacological products we have, such as Sativex, next slide, Daniel, or Nabilone, and some of the pharmacological, Health Canada, FDA-related products. And these are not what our Canadians are using. And these are not what people have been telling us for decades has been helping these conditions. And so, the three studies I have up there are just a snapshot of where our approval came from Sativex and some of these things. So if you had multiple sclerosis, you could use Sativex. And what is Sativex? Sativex is a one-to-one, similar to these oils you can find in the marketplace, of THC and CBD, so tetrahydrocannabinol and cannabidiol, and they have very different effects. Cannabidiol, more of an anti-inflammatory effect, which we're actually seeing that in some of our biomarker studies, and the THC effect is at that CB1 or that central nervous system level to downregulate your nervous system. You also saw some pretty good effects with Sativex in terms of these nerve injuries, so that neuropathic pain that we're talking about, and things of that nature. So next slide, Daniel. What we decided to do was to take a quick overview of about 600 patients that were coming through for orthopedic surgery at the Toronto Western Hospital. And of these 600 patients, the number, and we weren't surprised, were about 1 in 5 patients were using a cannabis product to help manage their MSK pain. And what were some of the biggest predictors were if you had a history of depression, if you had ongoing pain for more than a year. So the longer that you had your pain journey, the more you were going to gravitate towards using a cannabis product. But the strongest predictor was anybody who had already been using it recreationally in the past or is continuing to use it on an ongoing basis. And so we dug a little deeper into some of this data. Thanks, Daniel. Next slide. And, what was interesting to us was, it wasn't the CBD for all story. About 1/3 of patients were using CBD, whereas 1/4 had no clue what they were taking. 2/3 were using cannabis to manage their pain. And you'd figure that the other 40% were the sleep issues, the social anxiety that you hear a lot about. And 1/3 of patients were probably spending about $100 a month on their cannabis products. And I often say to my patients, if you really want to use this as a health tool, you will be looking to spend anywhere from $80 to $150 on a monthly basis to find a product that you might find some benefit from. And only about 1 of 4 of these individuals were even advised by a physician regarding their cannabis use. And 1/3, as I stated before, were using this from a Health Canada licensed producer. So when you think about the numbers of patients that are using cannabis, if we have 2.7 million individuals and only 1/3 using it from a licensed producer, you can imagine that $200 million a month is potentially a drop in the bucket of how big this economy potentially could be from cannabis. And so we went ahead and we published some perioperative management guidelines for those who are coming in for surgery using cannabis. And so you'd be happy to know that if you are someone who is using cannabis and you presented at UHN, we would have a pathway for you. And if you had an authorization for your cannabis, we could actually help you through your perioperative time period, knowing what it is you were using, et cetera. Next slide, Daniel. So I'm just going to focus in on this study and then wrap things up and ensure that we have about at least 10 to 15 minutes to talk about all of the information that's been thrown at you. So next slide. This is a study of almost 1,000 patients that were enrolled in, at the time, Cannabis RX clinics in Ontario. So this is from 2014 to about 2017. And it took quite some time to get this published because, as you can imagine, there are no products we've ever been able to use in an RCT in Canada, randomized controlled trial, that may be changing in the coming months, given some of the new Health Canada changes. But of the 1,000 patients that we approached, 757 of these individuals completed baseline, purchased a cannabis product, and these were predominantly patients looking for pain relief. At 6 months, we were left with about 230 patients completing the 6-month follow-up. And so you can see there was a lot of dropout. We had a lot of pushback in terms of presenting this data. But my point to the reviewers, et cetera, and the rest of the world was, if you see any intervention where 1 in 3 individuals continue on these medications at about 6 months, you're going to have a signal there that probably is meaningful. And that's kind of how we move this forward. There's absolutely a positive bias in terms of those folks that who dropped out probably weren't finding benefit, or perhaps were having some side effects that we were unable to capture, and we're trying to fix that. Next slide, Daniel. Click one more time and it'll show you a little red bubble. And this is just to show you that, most of these folks were using it for pain, as I mentioned, above 90% of those that were enrolled. Next slide, Daniel. And give me the next bubble as well. And this one shows that really and truly, if you're using cannabis for a medical purpose, and at this time, again in 2014, much of this was inhalational. It's moved forward since that time. You weren't using more than 1 gram or 2 grams a day. So these individuals that are using 5 grams and 6 grams plus, you can see is something that is probably moving outside of that clinical kind of realm. Next bubble, I think as well, Daniel, to show you that at the start, many people were using dried products. And by the 12-month period, you saw it layer out to more of a 50-50 in terms of oil and plant-based products. So next slide, Daniel. And you can click 2 more times and give me all of my circles there. And so this slide really just highlights, if you can back up, really just highlights the fact that if you are looking at, pain-reported outcomes in particular, we always talk about this opioid sparing effect. And I can tell you that when people started in this kind of 1-year journey or, 6-month journey, if you look at the robust data, by the time we moved from the start, which was about a 50-50 mix of individuals using an opioid for pain, by the end of this, we were only at 20% of individuals using their opioids on an ongoing basis. So again, some early evidence, this is not a randomized controlled trial, to show that there's truth to that potential story, that adding another agent can help you reduce your opioids overall. Thanks, Daniel. Okay, so, we were able to, at the end of the day, show an overall reduction in pain intensity, in pain-related interference, and overall improvement in general health symptoms. Health Canada has reached out to us about this data and is actually looking to partner with us potentially for some of the work I'm just about to finish up with. So next slide. So we were lucky enough, to be part of not only creating these neuropathic pain guidelines, which were able to move cannabis up to the 3rd line several years ago. And many of the other countries have followed suit in terms of Europe now agreeing with us. They didn't agree with us at first, that, cannabis can be in that upper tier of medications that can be trialed for neuropathic pain. Next slide. I'm going to pause here because I think it's an important point to ensure that we all understand that there are side effects to cannabis use. All of these things that you hear about are actual issues, the ability, especially in young adolescents, schizophrenia, psychosis, cannabis use disorder, all of these things are things we have to be concerned about, even in the adult world. But, when your brain is fully developed, we're looking at doses that are significantly lower than what, adolescents are typically consuming. And the understanding of dosing in general is not one that is well supported in the literature or by many people that are authorizing these products for that matter. So next slide, Daniel. we were able to win one of these grants, and we now have a pretty robust infrastructure to look at cannabis and osteoarthritis. And so these are some of the three gentlemen that I'm working with. And next slide. Next slide. And so I'm going to finish up with our medical cannabis real-world evidence trial. And so this is something that I think any of you can take a look at. The website is www.mcrwe.ca. And this is a coast-to-coast look at cannabis in the Canadian population. And what we're doing here from a study design perspective is enrolling anybody with a chronic pain, a sleep, or an anxiety issue. And at baseline collecting data, you'll then be able to purchase your product. It's not for free because it's observational. At 6 weeks, 12 weeks, and 24 months, collect this ongoing. Any physician anywhere in Canada can enroll a patient into this study. It's been already approved by Veritas and UHN. Next slide, Daniel. Why do this? And so there's a backbone here to understand that every product you're going to purchase via this partnership has been tested to accurately relate what is on the bottle to what is in the bottle. And so, believe it or not, that is something that we're still working out in the background as this industry has moved forward. Next slide. We have third-party labs that test and then feed information into this, as well as the actual licensed producers that create the products that have been partnered. There's about, I think, 40 or 50 of them now that have partnered into this infrastructure. Next slide. This is the website I just mentioned. It's got the patient portal side so that you can understand what the potential benefits are and how the study flows. And there is a healthcare practitioner side in terms of figuring out how this can be beneficial for their purposes as well, to understand whether this is helpful to their patients. Next slide. And this is pretty much my last slide. And what we have done for the past 2.5 years is build a syllabus for physicians in particular that are interested in understanding how to go about safely integrating cannabis into people's potential regimens. So next slide, and I think I'm going to hand it over to Paula and Courtney to wrap up, and then we'll take some questions. Thanks, everyone.
Thank you very much, Dr. Clark. So to our audience, please submit your questions via slido.com, and the code is liver. So slido.com, and the code is liver. So we've had two very, very comprehensive presentations, and I know that there are a number of questions that came in before the presentation. So some of these questions may have been addressed, but it's always good to go back and potentially emphasize some key messages that are important. So our first question is regarding, I guess, differences in terms of liver surgery. So this person is planning to donate to her aunt and wants to know what kind of pain they should anticipate. And they've heard that pain and recovery is worse if they're donating to an adult versus a child. So if they're donating left versus right lobe of the liver. So I'll turn that over to Dr. Clark.
Sure, and as this speaks to liver, it really, I think, relates to the incision and the type of incision. And so often when you're donating the lobe to a youngster, you don't need as extensive as an incision. And so you can get away with a midline incision and the pain isn't typically as bad. One of the more painful incision is that hockey stick type incision that patients have. So, you can anticipate that you'll have a bit more pain, but, we'll be here to hold your hand and ensure that you get the medications you need to get you to the other side.
Thank you. And I see that there are a number of questions relating to pain, but there are also some relating to prehab and rehab. So we'll get through all of those. Again, for Dr. Clark, are there any topicals you recommend for incision pain?
Sure. I mean, the most basic topical is one that I'm sure many patients will try by themselves. That you have over the counter, even lidocaine. You can get extra strength 2 to 5% type lidocaine products. But where we often land in the chronic pain world is if you can find a doc that has familiarity with some of these topicals, we can actually add things like gabapentin, like ketamine, and have other binding agents in there that can keep these things stable, and you can use those for your incisional pain. And so there are many topical formulations that can be created for you.
Mhm. And are these able to be used over sort of a long term? Because there are some patients who experience pain, incisional pain, over a longer term.
Yeah, Paula. So, it really just comes down to the efficacy of topicals. I would love to say that topicals are the godsend. There are some that it works well in. I won't say it's the majority. And if you're one of the lucky ones that find a topical that works for you, then you can certainly use it over a long period of time. It's not cheap. These are compounded products that are put together. And so one of the limitations is often the cost as we start to add specific agents to these topicals. If you have a good private plan, which some of these Trillium patients don't typically have, it can be a problem sometimes for the topicals.
Mm-hmm. That's a good point. Certainly, we've had some discussions about the cost of medications. Just before we move to the next question, are there, some differences in terms of coverage? For example, is cannabis covered under, drug plans?
So the only two conditions that I think you can potentially in Canada even have a hope of getting covered for cannabis is, given the Epidiolex story south of the border and having pediatric epilepsy in particular, you may get some compassionate coverage for a child in particular. If you have multiple sclerosis and you have spasticity and you have neuropathic pain as a consequence of that, I have seen some coverage. But again, you have to have multiple sclerosis. So for many of the things that people are looking to use cannabis for in Canada, there's zero coverage. I often get the ask of, can we try? I've tried a few times. We will never get coverage until we move the science forward. Hence some of those last slides in the MCRWE study that we're talking about. And until we get Health Canada's approval to actually use some of these products in clinical trials, we're nowhere near that.
Mm-hmm. All right, moving on to our next question. Now, you addressed some sex differences in one of your slides, but can you speak to sex differences in sensitivity to pain or response to pain medication?
Sure. I mean, this is a massive question. It's a very easy answer. There's absolutely sex differences in sensitivity to pain. One of the things that Health Canada has made sure is that you must have all of your trials, assess the effect on sex and gender, for that matter, moving forward. So,
Mm-hmm.
easy answer, yes.
Yeah. Is there an age difference?
Here's what we find. I can tell you that as you get older, you've probably experienced pain more in your life. And so one of the things that we find are the younger the individual, because of this concept of health that Daniel mentioned, you're younger, you're healthier, but are you actually healthier? We get our hands tied sometimes in terms of being more aggressive in terms of treating pain in the young individual. But that's where pain at its first experience, severity could be being felt by some of these individuals. And so their response can be much more exaggerated. And I always find it interesting that if you're in your 70s, 80s, and 90s, as an anesthesiologist, I can put needles anywhere because I can do anything I want to. But if you're younger, because you're healthier, my hands are kind of tight. We don't want to do too much to these individuals because, they're so healthy. And so it's a bit of a dichotomy and a bit of a balance there.
Mm-hmm. I guess also good to keep in mind in terms of the differences between donors and recipients, mm-hmm. Donors tending to be younger, healthier, etc.
Yep.
All right, on to the next question. Does meditation help manage pain? And can you comment on complementary medicine and pain management?
So I could have easily had some more slides in there. We just finished a yoga intervention postoperatively. Obviously, you're not doing downward dog and things of that nature, but it's a more gentle yoga program that Daniel was part of as well. And so we found that certainly there were some pain reduction and actually, if I'm not mistaken, pain interference improvements with those who performed yoga. So we're a very open-minded program. I find that your brain can help you with your pain management as much as any medication I can give you. And so we are open to all of it. And absolutely, I have no problem with people trying other alternative medicines as long as they find a benefit.
Mm-hmm. And I guess it ties directly to the next question around the positive mindset. What role does that, sort of mind over matter, what role does that play in terms of pain management?
I think it's huge, but I think more than that, it's the patient's willingness to be involved in their care and not a passive recipient of their care. And so you will always have the best outcomes when it's a partnership and not, what is the next thing that you can do for me to take this away? And the fact is we can't take it away. We can just help you cope and live your life.
Right.
So sometimes
right.
a tough message to hear, but it's we say it often and early, and so that the truth is kind of there.
Mhm. Absolutely. And it sounds like your program is really all about trying to give options for patients and putting more, giving patients power to manage their pain as well in many ways. All right, so on to the next question. I think we've addressed the matter of faith perhaps, but do you want to comment on that at all?
Just in terms of religious,
Yeah,
like your faith.
yeah, and
Yeah, I mean, again, that's using your mindset and your belief and your, whether that is in a greater being or in existential greatness, whatever that is. It certainly is helpful for individuals to have something to look to.
All right, so our questions related to pain management continue. I promise, Dr. Sandamina, that we will get to you. All right, this next question is around habitual marijuana use and whether it influences response to pain medications. I know that we do ask questions, for example, of living donors, who are applying to be assessed for donation, and obviously are also looking at that for patients. So can you talk a little bit about this, Dr. Clark?
Sure, Paula. I mean, there's a huge issue here, right? And so the first thing is habitual marijuana. So marijuana, we're kind of moving to cannabis, and people get upset with that. Well, it's marijuana, it's ganja, it's this, it's been around forever. And the fact is, the term marijuana has pretty racist connotations. It was, from the kind of the parallel at that U.S.-Mexico border, and the whole reefer madness concept is associated with marijuana. So, and the other thing is that whenever you use the term marijuana, cannabis, people associate it with weed. And so, I can't really answer this question until we start to understand that what we're talking about when we talk about cannabis is, one, we have to understand the dose, and someone who's smoking to get high obviously will have issues in particular with response to their pain meds, because your levels in terms of how much cannabis and THC you have in your blood will absolutely affect your response to pain meds. There's no doubt. If we're implementing this as a medication to help blunt, what people are seeing from their nerve related pain or their myofascial back pain, where I've seen wonders with CBD, surprisingly, I didn't believe I would see that. And they're apples and oranges. And we haven't even gotten to the place where marijuana or weed or cannabis is even understood. So just because someone, smokes a half a joint at night, does not equate to someone using a cannabis product for, 3 times a day or an oil. And so the patients are very different. Each person presents using it differently, and we have to get to a common playing ground so we know what it is people are using and how they're using it to answer some of these questions.
Mm-hmm. And it is important to talk about this, I guess, during the assessment process, I guess, for long-term management of pain as well, and for management in hospital while they're admitted.
You're bang on, Paul. I've been approached by some of the Americans to create a kind of a pre-OR assessment of cannabis. And everyone's on board that this is something you should be asking everyone. Just like, if you're asking them about their heart condition, if they're asking, because this is now part of our society. So we need to know. And the fact is, it does affect your care, and it does affect your pain response after surgery.
Mm-hmm. Fantastic. All right, so maybe we can take the next 2 questions together because you did review pain medications that are typically prescribed to liver patients, while they're inpatients, and then following when they go home. But if you could, quickly review those and then talk a little bit about self-medication and any cautions regarding over-the-counter pain meds.
So I think we all know that almost any medication we take is metabolized by our liver. So if you're coming in for surgery, the good thing is we kind of take over what you're going to have in your body while you're in the hospital. So you'll be protected in and around surgery. And if your liver is healthy, I don't think you have to be too concerned about what you're taking prior to coming in for surgery. There's only one class of medication that really has no liver involvement that I use pretty commonly, and those would be the things like the anticonvulsants, so gabapentins, Lyricas, things like that. They're not metabolized by your liver at all and are completely just excreted by the kidney. So I wouldn't worry too much about that. Almost anything you take will be metabolized by your liver. There are some medications. So cannabis in particular has a direct CYP pathway with some of your anti-rejection drugs. And so this is where really being truthful with the team about your cannabis use is important, because it can mess with your tacrolimus levels and things like that. And something for patients to really understand, that it's not a minor oversight to not tell your docs you're using cannabis.
Great, thank you. All right, so I think we've addressed this question around pain meds typically prescribed. I don't know if there's anything you'd like to add here, but maybe we can move on to Dr. Santamina. So a lot of the work that was presented regarding prehab and rehab is very, very exciting. I'm wondering if you can comment on how you determine which living donor candidates would benefit from prehab, or whether you would recommend it for everyone.
Sure. Thanks for that question. The workup for a living donor is pretty extensive to ensure that the donor is a healthy person and able to donate. So I think when comparing the living donor to other surgical populations who typically have some sort of underlying disease that require a transplant, like Han said earlier, these things are apples and oranges. What I would say is, as a generally healthy adult myself, if I were going in for any surgery, whether it was orthopedic or for an organ donation, I would want to be in as good shape as possible. And that may not necessarily spare me from some of the usual discomforts associated with the perioperative experience, but could I recover more quickly? Would I experience less pain? Would I be able to manage and tolerate the surgery in a way that was less disruptive to my overall life? I think those are important outcomes that don't always show up in some of these quality of life scales and some of the measures that we currently have. So irrespective of your general fitness, I would say that for most people, whether it's psychological conditioning or physical conditioning, we can all probably be as well prepared for surgery as we could, even if we're not necessarily as frail as some of the patients who are assessed in these studies that we've described.
Great. And maybe we can address these two last questions together. When you talked about prehab and rehab, you talked about not only the physical, but also the psychological aspects. And certainly depression seems to be, an issue that affects many people pre and post surgery, and sometimes prevents people from donating or from having surgery. And you also shared some tools that are currently being used to track outcomes. I'm wondering if you could talk a little bit about how what kinds of things are important to address, or you're thinking of addressing as we move forward at UHN with some pilot testing of these programs more extensively within transplant, and also how we track whether in fact we are having an impact.
Sure. So with respect to depression, certainly it does have obviously a very significant mental adverse outcome, and it does also implicate a number of outcomes, is implicated in a number of physical outcomes as well. When it comes to depression and other psychological morbidities, we do try to screen for them at the time of treatment decision making or time of diagnosis to understand whether or not this is an area of health that needs to be addressed. And I think that this is a bit of an evolution in some of our rehabilitative approaches, whereas we don't necessarily just look at physical frailty, which probably is the one area that we've consistently looked at, but now more often than not we are looking at psychological health as well as a predictor of surgical outcomes and screen for that. And to maybe tie this into the idea of how do we track outcomes, how do we screen and follow up, and so on and so forth. We do it via a mixture of methods. Certainly what we usually do is have an inpatient assessment that's fairly comprehensive, that looks at the holistic person, or looks at the person in a holistic manner. Mental health, physical health, medical optimization, and so on and so forth. In many ways right now, we're restricted in what we can do physically. So we do a lot of these things virtually. We don't always get as much detail from a virtual physical assessment as we would in person, but we do our best in that respect. And in the absence of physical assessments, many of our measures are in fact surveys that are typically valid and reliable using the research literature. In areas where we don't have a survey but specifically pertains to prehab, it's often embedded in a fairly comprehensive health history and medical interview.
Great, thank you. All right, so we've reached the end of our questions and of our time. I'd like to thank our speakers, Dr. Santamina and Dr. Clark, for joining us and sharing their expertise. I would encourage all of you to join us next time for another webinar on, this time on the topic of creating a culture of organ donation and transplantation. Some of our partners and clinicians involved in research at UHN are also going to be presenting at upcoming conferences, including some work that we're doing to improve access and equity in living organ donation. So consider registering for our upcoming conference with the University of Ottawa, which will take place on June 17th and 18th. So once again, thank you to our speakers and thank you to all of you for joining us today. Check us out on social media and we'll see you again on June 24th for our next webinar. See you then.